Dr. Khan, give me your name, rank, and serial number. Tell me who you are.
This is Dr. Shaher W. Khan. I'm a board-certified general surgeon. I'm also a board-certified plastic surgeon.
And where do you practice?
So I am located here in Bloomfield Hills, Michigan on Woodward Avenue.
You are double certified. Why is that important?
So the underlying basis for plastic surgery can be neurosurgery, orthopedics, ENT, or in my case, general surgery. So I'm a board-certified general surgeon. That means I can operate on the chest, on the head and neck, and also lower extremity, including all abdominal surgeries. Now that lays the foundation for plastic surgery, which is all above the skin, if you will. And then at that 5-year level of training as a general surgeon, it gives me the platform to build up and enhance my plastic surgical skills.
And in some of the plastic surgeries that you do, you need general surgery skills because some of them require general surgery actions, don't they? For example, in taking out a breast implant and taking out, this becomes a general surgery, doesn't it?
That is correct. So a perfect example would be the patient that came to me from California. She wanted to do a mastectomy with me when I was doing an explant, and she would not be a candidate because she needs to get sentinel lymph node biopsy and she needs to get her lymph node evaluated. As a plastic surgeon, my role is to remove and manage implants and not to do an oncologic cancer operation, given her history of breast cancer. So she would need to be only managed in an operating room at the major hospital and not at an outpatient surgery center. So having been a breast surgeon slash general surgeon and having managed a lot of patients, I'm trained to know exactly what I can do and what I cannot do in a setting such as this.
Some plastic surgeons are not board-certified general surgeons. Does that limit their practices?
That is correct. We have a group of doctors out there, unfortunately, who are practicing, who are truly not trained in the right professional manner and the ethics and also the technique of surgical intervention when it comes to plastic surgery. Plastic surgery is a different offset of general surgery. Now, there are a lot of ENT doctors who are unfortunately practicing plastic surgery and also general surgeons right here in the area, but their level of scope and training is very different compared to a plastic surgeon who has officially been trained and basically has met the right board requirements, exams, oral and written, so that they have the knowledge and understanding and the application of this knowledge at world reputable centers.
Well, let's get into breast implants now, and especially breast implant illness. What is breast implant illness?
So breast implant illness, basically, it's a constellation of signs, symptoms as a result of the silicone toxicity. As you will hear, the many patients, even with saline implants, where the shell of that saline implant is made up of silicone, or a silicone implant that's present, it leaches out silicone particles and the body recognizes it as foreign. And as a result, the immune system goes haywire and now the body in itself becomes reactive. And this essentially translates to hair falling off, neck, back pain, fibromyalgia type symptoms, dryness of the eyes, endocrine, hormonal problems. You have patients with chest pain, you have difficulty with breathing, you have contractures that occur, GI disturbances, connective tissue, joint, neck, back problems, which are the hallmark features, fatigue, and literally touches every organ system of the body, some more, some less, some not at all. And the implants, as you will see, because of their reactive nature, cause what is this silicone toxicity and reactive syndrome, which manifests in what is the symptoms that the patients complain of over the years. Now, this may start off with nothing and may start declaring itself at the 7-10 year mark from my experience anecdotally, but it can occur a day after or maybe 20 years later, but not everyone will get it. And this is where the body is reacting to what is a foreign entity.
What is called breast implant illness has become kind of a popular, well-known term, even to people who are not medical experts. However, it's not an officially recognized entity. Why is that?
Unfortunately, the way the implants are marketed, especially after 2007 as the gummy bear safer implants, the medical community was led to believe in general, this is the primary care doctors and certainly the patients, that these are the safer, better implants, the fifth and the next generation set of implants. They unfortunately decompose and break down just like the older implants. And we have the same set of problems that the ladies in the early 90s that led to the ban of silicone implants in 1992. So we have the same set of problems from brain fog, fatigue, and all these symptoms that I mentioned, not present in all, but this is the same set of problems, which truly, if you look at the manufacturers and if you look and listen to the FDAs, and certainly, most importantly, if you listen to the patients, they are certainly bringing this forth to the attention of the masses of the medical community and the community in general. And you will see not only the patients, but also the celebrities who are coming forth getting explants and declaring freedom from the silicone toxicity.
So while this is not officially known as some sort of a medical problem, it's recognized as a medical problem. What will it take, for example, the medical schools to start teaching about this and the other things that would happen when the FDA would suddenly say, yes, there is breast implant illness?
Yes, so a few years ago, the FDA stepped up and made what is this black box warning, where it clearly highlighted that breast implant illness indeed does exist. It is being well recognized by the Plastic Surgery Society, but well not known, popularized. And this is something that ultimately is slowly being translated. We see the many patients, literally in the hundreds of thousands, not only in the United States, but all over the world, slowly recognizing this entity, and they themselves are taking the initiative on social media, be it Instagram, Facebook, YouTube, or TikTok, and bringing forth and alerting and alarming the other patients as to the detrimental effects of the implant. Certainly, as you will see 5 years ago, the number of discussions and platforms discussing breast implant illness was very limited and minute. Nowadays, it is not uncommon for every plastic surgeon in every major state, in every major city of the United States to have on their website breast implant illness, and they themselves are actively discussing the management of what is this very serious and real problem.
What was the role of social media in making people aware of this?
So a very good question. As you will see, if you go to any general practitioner, nurse practitioner, or PA, or a primary care doctor, and you ask them about implants, they will say they are safe because they probably have not even touched a breast implant in their life or their career because they did not do a plastics rotation. Now, the patients themselves, when they heard that there are other patients who were explanting, especially when the celebrities came forth, there was all of a sudden these young ladies, young moms, grandmothers as well, and ladies in the middle ages who said that they knew they were hurting. They had gone to their doctors and they had gotten a variety of tests, lab tests, and imaging, all being normal. And they were now being told that this was all in their head and this was the stresses of society. And now they took it upon themselves to override their local plastic surgeons and their primary care doctors, and then to take this decision to explant in their own hand. Only then did they realize that indeed it was truly the implants. And now then they truly put this forth as video testimonies, verbal attestations to their freedom from the silicone toxicity. It has now gotten more and more recognized. And this is one of those things where you don't have to advertise, because if it's the truth, like we all know, like in the 90s, it will only rise. And now over the next several years, you will see that it is only going to get more and more recognized. And this is certainly in a very objective way, clearly shown on the Google searches. If you go back to 5 years ago, the number of Google searches for breast implant illness was essentially non-existent. And now you have an exponential increase where a lot of patients are doing the homework and networking and research and concluding that it is the implants that is hurting them.
Women who have breast implants will hear this. What can they do to see if they have breast implant illness?
So the first and foremost thing is you have to arm and you have to learn and you have to get the knowledge of what it means. Joining a Facebook group page such as mine is going to be very critical and essential to listening to not only what I am saying, but most importantly, what the other patients are saying, because that is essentially the force that's driving this and the momentum that it has picked up over the years. So listen to the many patients. There is a certain etiquette into removing the implant. Anyone can remove the implant, but the whole surgery in my practice is dependent on not only removal of the implant, but also the capsule and the inflamed tissue around, such that there is no inflammatory burden left behind. And let's say if your surgery was done today, you would have two confirmations. Number one, that entire capsule and implant and inflamed tissue is removed sincerely completely, wholeheartedly, religiously, honestly. And number two, all what is removed is then sent to pathology to make sure it's not that very rare lymphoma that is associated with the implants. It's not breast cancer. It's not abnormal pathology. And we see on the pathology the chronic inflammation. So you have that second confirmation that it was tested and there was not cancer, that relatively very rare cancer, and that you have the peace of mind that you have freedom from any potential toxins that the implant and its surrounding tissue may have left behind.
So step back a little bit. Is there an official battery of tests to determine breast implant illness?
There is no test to diagnose breast implant illness. It is essentially a diagnosis of exclusion, which basically means that you have ruled out anemia, you are not hypothyroid, you don't have adrenal issues, you don't have lupus, Lyme disease, you don't have any of the other ailments such as rheumatoid arthritis. Once those labs are all ruled out and you have seen the subspecialists, and all the imaging supposedly is all negative, then you have more and more fingers pointing towards what is breast implant illness. And essentially, as I mentioned earlier, it's a diagnosis of exclusion.
Dr. Khan, in your opinion, are any breast implants safe?
So ultimately, as you will see, the first line that the FDA warning says, breast implants are not lifetime devices, close quotes. And then, if I may, the next wording is the longer patients have them, the higher the chances are that they're going to have problems, some of which will require more surgery. And this in itself means that if 100,000 ladies get implants, ultimately, they will need to get that removed or replaced, and they are not lifetime devices. So it goes back to the point, you have the same set of problems that saline implants cause as same set of problems silicone implants cause, and certainly the same set of problems that patients with ruptured silicone implants. So you can interchange these three groups. And overall, breast implants are not worth going through the pain, suffering, and misery of what the patients are reporting.
Do you think most women realize that breast implants are not permanent?
Believe it or not, they are being marketed and told by the many plastic surgeons that the implants will be with them forever, which is absolutely 100% false and incorrect. The implants need to be replaced anywhere from 10 to 15 years, depending on the signs and symptoms. They need to be monitored closely by a board-certified plastic surgeon, and the signs and symptoms need to be very carefully managed. This is part of that informed consent. So any young lady or old, maybe after breast cancer, or she's deciding to get it for cosmetic reasons, needs to understand, needs to get that informed consent. What are the detrimental effects of breast implants? And in literally 30 seconds, you have patients with infection. I had a patient yesterday that she said her aunt was in the ICU because of sepsis from implants. Capsular contracture that indeed can occur at grade 1, 2, 3, and 4. You have acute and chronic pain. You have malposition. You have that very rare lymphoma, the BIA-ALCL, which is the breast implant associated anaplastic large cell lymphoma. And also by the FDA, what was reported to be BIA-SCC, which is breast implant associated squamous cell cancer. You have patients who are afraid to getting mammograms because they're afraid that the implants might get hurt. And now the self-monthly breast exam is not being done optimally because the implant is getting in the way, or the patients are afraid to getting mammograms. Both of these are very important tools to detect breast cancer. Remember, 1 out of 8 or 9 women will get breast cancer. So that is a significant number. So the screening by self-monthly breast exam and also mammogram is critical. You have patients that report that they have rippling, they have skin protrusion, for example, because of the implant falls through the muscle and consistent with the malposition. Majority of the patients don't even know that when the implant is placed below the pectoralis major muscle, the muscle is cut and it compromises the upper arm function, shoulder function as well. That certainly affects not only the posture, but the athletic ability of this young lady, or even the middle-aged lady as well. And so there are a lot of hurts, including rupture, and also the many other symptoms of breast implant illness as highlighted earlier. So if you listen to just the detrimental effects and you tell any person with an open mind that these are the problems, I promise you no one would want to even think about getting them, because no one would want to ultimately be hurt by what is a implant that has already been bad before in 1992.
A lot of people think, if they've looked into this, that maybe saline breast implants are safer than the silicone. Are they?
I will tell you, if you look at my practice, the patients with saline implants come back with the same hurt and misery as silicone implants. We have reports clearly outlining these patients with saline implants intact have silicone within their lymph nodes, not only within the lymph nodes in the armpit, but also within the lung tissue and other tissues, not everyone. And so this is the silicone leaching that is occurring from the silicone shell of the saline implant. And so clearly, as you will see, you do not want to, and I give the analogy, a cigarette is safer than a cigar. No, they cause the same hurt because it is ultimately the same problem that is causing the issue of what is the silicone toxicity, which is the silicone particles that are branching off from within the implant, be it saline or silicone.
So it's not just a rupture of the breast implant that can cause the problem. It's the actual plastic that's holding the material inside.
Yes, it is actually the silicone shell that is holding the saline inside that is the culprit. A few years ago, I took my saline implant from one of the patients, sent him to one of the doctors in the Netherlands. He's a PhD doc, Dr. 𝐸𝐻⁴, and I told him to take the fluid from within the saline implant. He took that 500 cc's of normal saline and he centrifuged it for an hour at 11,000 RPM, only to find out that there was a pellet that was collected at the bottom. And when he looked at it under electron microscopy, it was consistent with silicone spheres, consistent with if there is silicone leaching into the body, it certainly is going into that saline, and certainly it did hold true.
Is it known physiologically and scientifically what the silicone does to human tissue that causes problems?
Yes, so we see this in the pathology reports. Anytime and every time I remove the capsule from the patient, I send it off to the pathologist. And you will see, not in all patients, you have chronic inflammation, histiocytic reaction, giant cell reaction, a reaction to non-polarizable material consistent with silica, silicone mastitis. And you see this right underneath your eyes when you look at it under the microscope, the capsule in itself, because that's where the pattern is occurring. We know this from the textbooks clearly, where whenever any implants, be it saline or silicone, that is put in, there is acute and then chronic inflammation that occurs in 100% of the patients because of that foreign body reaction. And it is very well published and it's very well written in the plastic surgery journals and out of major centers such as Sloan Kettering and the many other publications.
Well, you've given us a pretty good list of problems and even explained what the silicone does that you can see with your eyes, problems that are caused by silicone. So let me get to an FDA question for you here. Has it been suggested to the FDA that they should ban breast implants?
So the FDA essentially is looking for feedback from the patients in regards to the hurt that the patients are going through. Their collecting mechanism of getting these complaints is not very well established, and the patients are having a hard time translating this into a voice that the FDA is comprehending and reacting to. We saw this black box warning, which is not to be underestimated. This was a major advancement into alerting not only the doctors, but also the patients about the detrimental effects. Now, I will tell you the tsunami of patients, the momentum of these patients is so strong, it's not going to go anywhere but to alert the FDA. And because these ladies are shouting and they're screaming on the Facebook and YouTube, and they are very determined and assertive and professional about raising the awareness. There is indeed a movement, if you will, a revolution, if you will, that is only going to let the FDA know that they have no choice but to put a halt, hopefully this time around, to not only silicone implants, but to saline. And this, if you ask me, inevitably will occur like it did in 1992. Back then, you had the Oprah Winfrey Show and the other talk shows. That was the major voice where you had the daytime talk shows alerting and kind of voicing the opinion and raising the awareness. Nowadays, you have the social media platforms that in itself is very well establishing the momentum. You have Facebook groups out of almost every state of the region, and surgeons themselves are getting together and voicing concern. There are many surgeons who over the years have truly stopped augmenting and they are only explanting. And there is no general consensus in regards to how the surgeons are operating, but they have clearly recognized, even the past president PSF Foundation and other presidents have truly recognized what is breast implant illness is a real entity, and hopefully the medical community will slowly but definitively embrace. It's just a matter of time before the alert goes out and the augmentation is going to be hopefully banned, and this time hopefully permanently.
So you think a ban will be coming in the future?
I believe so wholeheartedly. I'm an optimist, but I will tell you, if you just listen to where and how things were presented 5 years ago, 3 years ago, a year ago, and now, you will be very much surprised the momentum that the ladies have. We just need a few more celebrities to come forth and discuss, like Danica Patrick, for example. She literally brought in a lot of patients into the plastic surgeons' offices over the last couple of years. You will see that this other momentum where you have the celebrities kind of driving this, the patients themselves driving this. You have news outlets, you have Cosmopolitan magazine, for example, and other major magazines that are now bringing this forth such that it's a everyday, day-to-day discussion. There is no nurse that I have talked to at the hospital who has not heard of someone, or another doctor who has not heard of another patient who has walked in with symptoms of breast implant illness. So it is certainly becoming a everyday dinner discussion topic because the patients are hurting and they're looking for answers.
Well, doctor, you've explained why breast implants are not a good idea. Not a good idea. You even think that they should be banned, and you don't do breast implants. So a woman wants or needs a breast augmentation of some kind, let's say after mastectomies. What now? What is available to them?
So the first and foremost thing, let me use the example from the patient that came to me from California, from San Francisco. She said, I wish I had known my option number one was do nothing, flat-chested, which is where she is on that one side where she had the mastectomy. So they clearly need to be made aware that this is even an option. Majority of the patients are not even told that that's even a viable option. The second thing is do no harm. That is the whole take-home message in my practice. And if the patient wants to get implants, she should truly follow and be part of that informed consent so that she knows what she's signing up for. Now, other ways to manage this is, for example, someone has had a mastectomy, you can always do the DEEP flap, which is the deep inferior epigastric perforator flap from the belly. You take fat and you basically transfer it to the chest. Now, this is in itself a very long 6 to 8, 10, 12-hour surgery, but this is the patient's own native tissue. It has its own risks versus benefits, and this is where the patient certainly can seek this out. The good thing is this is patient's own tissue. It's not reactive, and when done right, it's a permanent fix without any problems, and you get a tummy tuck out of this as well. Now, this is a surgery I myself, for example, knowing what I know, would not do if I was a woman, knowing the length and the overall effects of doing the surgery. Sometimes fat necrosis does occur, and this is where you seek a microsurgeon at a major reputable center because this is the only place where these surgeries are done. And so that is certainly another very realistic, natural option that the patients can strongly consider. Now, if there are patients who are wanting to get an augmentation, there are other techniques that have been developed by other surgeons where you take the own tissue and you essentially roll it up such that it overall gives you a lift, and you use those same volume, sometimes fatty tissue on the side of the chest that essentially adds volume to the chest, and the patient does not end up getting a lift and does not end up getting an implant for that reason. And this is where you're utilizing the same tissue. Now, the other question is, I will never know what it is like to have breast tissue or what it is to have that concept of how I need to look. But if I'm 65, I will tell you my general consensus is I'm not going to get a facelift, neck lift, thigh lift, arm lift, because you know what? I would certainly hopefully be a candidate for it. But does that mean every patient who's 65 must get a mastopexy or breast lift or a neck lift or a facelift? And the answer is, in my practice, and as simple as it sounds, and it is contrary to the plastic surgery principles, where you want to, even if you're 75, look like you're 35, you do not want to look unnatural. And I will tell you, this is a choice that the patients need to make. And sometimes it's okay to have gray hair. Sometimes it's okay to have a few wrinkles and do no harm. As you will see, there was a surgery that I was doing where I would say a world-renowned surgeon that I was working with, and the patient had a redo facelift. Remember, even the facelift will last 10, 12 years, and the patient ended up getting a branch of the facial nerve cut, or you see one side of the face is not the same, or another lady that had ptosis, i.e. drooping of the eyelid because the surgery did not hold true, and it does happen. Another patient had, quote, what I would say, an effect on the face that no matter what, you can always tell she had surgery. And you see all the horrific plastic surgery disasters. Now, this is obviously, I'm focusing on the many other surgeries that are done, like the Brazilian butt lift, for example. I'm not a big fan of that at all. And I think ethically it should not be done at all. And the board and the society and the medical community should basically ban this operation, which is what I would say is the top one or number two operation that causes demise. It causes a lot of hurt, and the patients overall, yes, they may seek some initial benefit, but ultimately there's a big price to pay. So the bottom line here is, and again, this is the philosophy, the mentality that I have in my practice: do no harm, less is more, and you can achieve a lot of greatness and success by getting a good night's rest, eating healthy, eating organic, not smoking, not being out in the sun. And as you will see, even alcohol intake has been shown to decrease elasticity and add years to someone's face and the rest of the skin, and certainly hurt the body. And as you saw, the Surgeon General's warning after the New Year's in regards to the hurt that the alcohol causes. So overall, the take-home message is you don't have to unnecessarily do something that may ultimately end up harming you, that you may think may be an initial short-term benefit.
Breast augmentation, not including implants, but doing it the other way that you just explained, one or two ways of doing it, a major reconstruction or a less complicated augmentation. You can provide those, right? You do those.
So I will tell you, for me, like, say, for example, I don't do the deep flap because it has to be done at a major center, and the patient has to be always admitted to the intensive care unit after. So if a flap goes down, you have to be available at 4 in the morning to go back to the operating room. And it's not uncommon. It does happen. It is an expected problem that sometimes may occur. But in the setting that I am in right now, I do not do that. I'm not trained in that setting. This is a sub-select group of plastic surgeons who will only do this operation. So for example, here within Detroit area, major medical centers of Michigan, you will see there's less than 10 surgeons who will do this operation. It is not an operation that is done routinely at every major medical center. Now, going back to the point where, so when the ladies get a cut around the nipple areola and inferiorly, laterally, and this operation is done around the breast, you will see that certainly does alter the palpation, i.e. the self-monthly breast exam. It does lead sometimes in some select patients with nerve endings that are affected to the nipple areola, scarring, hypertrophic scarring. Sometimes in some select patients, you can imagine a scar may be not only unsightly, but you may feel some irregularities or hardness. And a self-monthly breast exam now gets compromised, where you're picking up on that 1 out of 8 or so breast cancer that occurs in the ladies. Or when you do your mammogram, you do not want to be getting one, and now you see what are calcifications or irregularities that may lead to an unnecessary biopsy. So when it comes to the breast tissue, I say, do not touch unnecessarily. So I'm not a big fan for that reason for doing mastopexies or lifts for that reason, because I would rather do another explant in that time versus doing an operation that truly my heart is not sold on. Now, having said this, I offered a lift to a patient last week because she truly needed one. She was young. She already had one. And so I felt that I could offer her that aesthetic look plus that physiologic return minus the implants that she had.
Explain that again. Maybe you explained it already, but what kind of procedure is that?
So as you will see, the first one is the deep flap, which is a big microsurgical procedure. The other one is where you make a incision on the breast lower part, and you essentially involute or turn inward not only the breast tissue but also the fatty tissue, and you essentially recreate the breast tissue such that it gives the patient a lift and volume up on the further upper part of the chest. Because essentially what happens over time, the breast tissue starts to gravitate down, sags, elasticity of the breast tissue gets less, and certainly the skin. So you essentially remove the excess skin and you lift the whole breast tissue up, and it's been relatively very well popularized, especially in some European nations where augmentation is relatively very expensive and the patients choose to have this surgery done, and it is relatively very well tolerated. and overall has a good aesthetic result.
Is any fat taken from another part of the body?
They do not do that. Now there is a
And you do not
I
do
do not do that. I don't like to do that, again, for the same reason. If there is fat transfer that is done to the breast area, and where the fat is fanned out and layered out in multiple layers, and we all know this is well established, some of the fat does take and certainly adds volume to the chest and breast area, which is very good, which is what the desired goal is. But you will see a good part of the fatty tissue that's transferred does get absorbed by the body, and that's loss of volume. And some of it will form nodularities and fat droplets and hard masses that may potentially complicate a self-monthly breast exam or even a mammogram. And I've seen this happen even from the best surgeons who have operated and done fat grafting, because this inevitably occurs, some less, some more, depending on the blood supply and depending on the technique of how the fat was placed. And now you see these patients who unfortunately cannot get biopsies because this fat droplet is very close to the breast implant. And now the radiologist or the breast surgeon is afraid to get a representative biopsy because they're afraid they might puncture the implant. Or number two, now they're doing serial mammograms or MRIs and watching a mass that may potentially become breast cancer and was never fat necrosis to begin with, or dead fat. And so for that reason, I say, and I don't want to use the word aggressive, but very appropriately, I say malpractice, because you do not want to mask a breast exam where, again, 1 out of 8 or 9 women will get breast cancer. And now you're only complicating and making not only the patient, but the doctor more anxious that if this is breast cancer, we do not want to potentially get it late. We want to get it early on so the patient does not have to undergo chemo radiation or does not have to undergo a mastectomy.
So more and more women are coming forward to you, and even some other doctors, but they're coming forward to you because they have learned about the problems of breast implants. They think maybe they do have breast implant illness, so they come to you for explants. More and more women are willing to get those implants taken out.
That is correct. And believe it or not, they come to me not only from Michigan, but from literally every state of the United States. And if you go out into my lobby, you will see just 2 days ago, very soon, I'm going to see a patient from Austria. I operated just last year alone, a lady from Switzerland, from Italy, from England, from India. These patients just made the trip for the surgery. The patients came to me in the past from Qatar, from Egypt, from Jamaica, from literally a lot of patients from Canada, from Mexico, from Hawaii, and literally from every corner of the world. I had a patient that came to me from Thailand this past year. And again, the point here is it's the same hurt, it's the same body, it's the same physiology and the same reactivity that these patients are having, the detrimental effects of these implants.
What happens to them afterwards?
Believe it or not, as you will see, if you join the private breast implant illness support group page, you will hear them basically get their health back. They will state the heal is real. You will see them literally post pictures of their weight loss, the inflammation water weight that they're carrying. You will see right before and after pictures of their faces, how they have dramatically improved as if they got a facelift.
Have patients come back to you telling you the same thing?
Believe it or not, they do it on social media, because remember, 8 out of 10 patients come to me from out of town. So I don't get to see them after the 3-5 days that they have been here, but I hear about them, I see them, I see their friends that they send over. So this lady from Austria, I've already operated on 3 of her other friends. And so this is by word of mouth, where the patients are talking to each other and they are celebrating the freedom from the silicone toxicity. And the network by the ladies for the ladies is certainly very strong. And as you will see, if you join the Facebook group page, there is only one intended purpose, which is to spread awareness, to spread that emphasis on the fact that the implant needs to be removed along with the implanted capsule, and that this needs to be all tested so that the patients truly have that peace of mind that all of it was removed and all of it was tested.
What is it that you remove?
So I removed the capsular tissue, which is the foreign body reaction, that scar tissue that forms around the implant. Anytime anyone has any foreign body within the human, be it a pacemaker or a lap port or anything like that, you will see a scar tissue forms, which is the capsule. So we find and we know from the pathology that we mentioned that the silicone particles leach into the periphery. And so it's insufficient, incomplete to only remove the implant. It is important to remove that capsular tissue around so that the patient gets complete recovery and not partial recovery.
So taking it out is more difficult than putting it in.
Very important point. Yes, putting them in takes almost 1 hour, 45 minutes to 1 hour. Taking them out takes me approximately 4 hours. So I book my patients for 4 hours. Putting them in is very easy. You make a pocket and you slide it in and you are done. Literally 20, 25 minutes each side. Removing them takes 4 hours because I have to remove that capsule that is super tightly adherent to the rib, to the pectoralis minor muscle, to the fascia of the serratus anterior muscle, which is right on top of the chest. And that is indeed what is the hardest part of the operation. If you ask 10 plastic surgeons to do this operation, 9 out of 10 will feel uncomfortable, and the 10th one who would want to do it will attempt to do it and may not succeed completely.
How can a woman tell if there's been a rupture?
The ultimate way on a saline implant, it's going to deflate completely. So that one side, just like a water balloon deflates, you will see that there's going to be a significant volume deficit on that one side. So the saline implants are relatively very straightforward. Silicone implants, as you will see, the manufacturers say MRI is the only ultimate way to pick up on what is a silent rupture.
So an ultrasound is not good enough?
Ultrasound is better than nothing, but not the ultimate of tests. So there are patients who have gotten ultrasounds and the implant was intact. And when they got the MRI, only then they saw what is the Linguini sign and the intra or the extra capsular rupture. And the MRI is extremely sensitive. It is no contrast and there's no radiation. It's relatively very safe and it's very precise and the best test that exists in 2025. Ultrasound is better than nothing. It's non-invasive and it's a quick test, but sometimes it misses. It has a negative rate, and this is a more practical test, but in reality, not the ultimate test. And this is why the manufacturers themselves say that if you have a silicone implant, you should and must get a MRI at year 3 of augmentation. And then every 2 years, they're onward looking for what is a silent rupture. I had a patient I operated on 2 weeks ago. She had both of her implants that were ruptured. And on my exam, I couldn't tell if she was ruptured or not. No plastic surgeon, no matter how much and what experience he or she has, even 50 years of experience, you cannot do an exam and say, well, this side is ruptured or not. And this is why the MRI is key. Realistically, you will see not many people get the MRI because the insurance is not going to support it. It was done primarily for cosmetic reasons. And even if the patients are paying out of pocket, they're so busy with their lives, they're not getting this study done on a regular basis.
Are women surprised to learn that breast implants are not permanent?
Yes, very much so. You will be surprised that when I read to them, now remember all what I have said today, there is no exaggeration factor. This is all hard evidence from the FDA website, the black box warning. This is the manufacturer's warning. And most importantly, this is the same highlight that the patients themselves are bringing forth. Because I would love to, sarcastically speaking, to be putting in implants. But I will tell you that young lady, maybe 5 years later, maybe 15 years later, she will come up with a problem, just like the FDA said in that first line. Breast implants are not lifetime devices, period. The longer people have them, the higher the chances are that they're going to have problems, some of which will require more surgery, period. And this is exactly as mentioned within that black box warning.
So that means that most women who have implants really are not going to go back and get them regularly checked.
That is correct. In reality, they're too busy with their lives. They have young kids, they have busy jobs and careers. And lo and behold, the general conception here is that unless I have pain, unless I have other issues, only then I seek attention. Now, my philosophy is follow the guidelines of the manufacturer. They're not lifetime devices, and the general consensus is 10 to 15 years. Now, sometimes sooner, sometimes later. This one lady I talked to today, she had a ruptured saline implant that occurred 10 years ago, and she's been with this asymmetry for 10 years. And she is semi-retired, and she says, now I want to go ahead and fix it now that I have time, and now I can worry about myself. You know, in the US, we have very busy lives. We have very busy agendas. And remember, when the surgery is done below the muscle, the recovery in itself is 6 weeks plus minus. So you are restricted and relatively limited with what you can do because this is the nature of the surgery. This is very analogous to if someone gets a knee replacement, you cannot be expected to go back to work in 2 weeks. This is not that type of surgery. And just like we have involvement of the chest wall, the muscle, and the whole chest on the right and left, the recovery in itself can and is relatively involved. And as you will see when you follow the private breast implant on a support group page, a surgery that is outpatient, relatively speaking, very well tolerated, and a surgery that, when done right, has a very predictable and positive outcome.
People have heard about breast implants, but a new term, breast explants, is now out there. People haven't really heard that term.
That is correct, because they do get confused. What is explant? And this is breast implant removal. That is the very simple term, breast implant removal.
You are one of the few breast explants doctors that anyone would ever know, and they come from all over the world to see you. Do you think that with recognition of breast implant illness and breast implant problems, more and more doctors, more and more surgeons will start offering breast explants because there'll be a greater demand for them?
Yes, absolutely. As I mentioned earlier, look and Google any plastic surgeon in any major city or even small city of the United States. You will see the term breast implant removal, explant surgery. You will see this on their website. They're actively discussing and taking care and managing the patients. Unfortunately, they're still putting in implants. Unfortunately, they're not removing the capsule wholeheartedly, completely. They're doing a lift and an explant in 2.5, 3 hours, including fat grafting. Their mentality and their concept, if you ask me, is certainly very different than what my approach is. My approach is to remove the whole capsule. We see that many ladies who have explanted, they have complaints that they have improved partially, and only then do they come back to me for complete capsule removal, because their previous surgeon did not do a complete thorough job. So this nice young lady from Austria that has come to me, and her 3 other friends that came to me, they have the similar issue. They already had their explant done back in Europe, and they did not improve but 50, 60%. And only when did I do the surgeries on these 3 other ladies and the many other ladies where I have done residual capsules, only then did these ladies improve to the point where they said, now I feel like I am completely relieved of the symptoms of silicone toxicity. There was another patient, for example, my first patient, she was a doctor. She works as an intensivist at a major hospital in the US, and she got her explant done by one of the local plastic surgeons at the top 5 institutions of the world. And her surgeon cauterized and burned the capsule right on top of the chest because the capsule was so thin. She said her symptoms are now worse than what they were before, and she's going to seek me out given her schedule, to the point where she has stopped working. She's on disability, and she promised me she's going to raise awareness from a different perspective, because she feels it's truly the implants, because she has exhausted every other avenue. And if you listen to the patients, I find this problem is occurring and has gotten out of control is because the medical community, the plastic surgery community, is not listening to the patient's complaints. They're being basically compartmentalized, and they're being basically grouped together as a small part of the problem. As you will see, remember, they're not lifetime devices. Eventually, they will all seek either a replacement or a removal. And you will see this is a group of patients where all will ultimately will need to be managed surgically, because they're not lifetime devices.
That's millions.
That is certainly millions. So every year in the United States, there are approximately plus minus 400,000 patients that get breast implants, be it saline or silicone, for cosmetic or oncologic cancer reasons. And there are patients certainly all over the world. If you look at that, there are, and over the years, from literally the 70s, you have literally millions of patients. One of the numbers that I saw was approximately 35 million people. Now remember, the implants have been banned, and they have had a bad reputation, and they have been only reintroduced into the market as safe gummy bear. Just 2 days ago, I did my Facebook Live, and I tell the patients and to the other surgeons and to the many primary care doctors, don't listen to my words, just see with your own eye what I have removed from the patient. And if you take that video and you take it to the 3rd grade and you ask them, what is it that you see that's coming out of the chest? I will tell you, they all will intuitively, within their sixth sense, say this is something that is not good, not safe, and should not be done. And this is exactly what I'm highlighting and bringing forth, so that the other patients who have it, who are hurting, they know that there is an avenue, that there is relief, there is a cure. Literally, I use the word cure, and that they do not have to live with the symptoms. If they have breast implant illness, they don't have to live with a rupture, and they don't have to live with a contracture, and that there is certainly relief that is very much present.
And that cure is Explant.
That is explant done in the manner that we have discussed with the entire implant, capsule, and all inflamed tissue. Now, does every single patient need this 100% of the time? To be blunt and correct, no. But you don't want to be doing this partially, and the next thing you know, it's a ruptured silicone. There's fluid around within the implant capsule and to that spill. God forbid there is that very rare lymphoma. Do you want to go back and remove the rest? Do you want to have, if your surgery is done today, in my practice, in my technique, if your surgery is done today, your surgeon is faithfully, completely removing the whole capsule, wholeheartedly, sincerely, religiously, and that this is the bond that the patient has with the surgeon. And number two, whatever is removed is then checked by the pathologist. And that is that confidence that the patient has that your surgeon is a firm believer in explanting, and that even, and I've said this many times in my Facebook Live, 20 years down the road, I cannot imagine anyone doing the surgery any better, any differently. I will mention there was a breast implant illness summit where a group of plastic surgeons from California, from Quebec, from Texas, we all got together and we were discussing with the FDA on a Zoom meeting on a Saturday, Sunday, and also with the Plastic Surgery ASPS Society. And the members accepted clearly breast implant illness absolutely does exist. There was the same question, does everyone need? And the consensus was they need the peace of mind that all of it was removed and all of it was tested. I have a patient here. She has CD30 positive cells, which is a concern for lymphoma. Her surgery is complete and done already by me. I'm not going to call her back to redo it because she got the complete removal. She got complete explant done. She had fluid around that was completely removed in the en bloc fashion, and she got the surgery that she very much deserved.
Are other doctors coming to you? Are you teaching other doctors this?
I will tell you, I have other doctors that I have myself talked to from Saudi Arabia, from Egypt, from California. They call me up, my other friends, my colleagues, and they ask, how is it that you're doing? And I tell them I'm going to have literally hundreds of videos from within the operating room that are graphic that I'm going to post on YouTube. And there are many that exist. So I'm going to show my technique, how I do it in the manner that I do, where the blood loss is less than 5 cc's in well over 99.5% of the patients, and that I'm very transparent. Every patient who wants to and they feel comfortable, I give them not only a set of high definition pictures, but videos of the chest wall showing complete capsule removal, because that's the bond I have with them. And this surgery is all about that transparency. And this is what I tell my patients. You know, the take-home message, especially after that young 41-year-old ICU intensivist emergency room doctor, that was the first consult that I did this year. Do your homework, do it right, do it once, and get your plastic surgeon to show you the video of the chest wall showing that he indeed or she indeed did remove the entire capsule off of the chest. And ideally, in 2025, your surgeon should and must not be augmenting, because if the doctor is augmenting, that means they are not firm believers of breast implant illness. So the many surgeons who have converted to only explanting, these are the genuine surgeons who truly have demonstrated that, remember, in the time that I do an explant, I can easily do 3 augmentations. So financially and also from a mechanical, physical perspective, it is much more tenuous surgery, much more challenging, a surgery that many surgeons don't want to even want to think of doing. And this is where your patient has that absolute confidence that your surgeon is a firm and authentic believer of what is breast implant illness. And there's only one motive, which is to get the patient back and healthy. There is no financial commitments with any Facebook group, private group entities. If anything, from a financial perspective, this is a very, I use the word foolish operation, because why hurt your body? Why hurt your soul? Why hurt, if you ask me, where it's a meticulous surgery when you can do it a lot faster augmenting? And this is the bond, do no harm.
So what is the message that you give to doctors who currently are doing breast implants?
So I tell them, if you listen to the many patients who are hurting and ultimately come back to you with problems, you ask yourself, why do something that ultimately is going to hurt eventually all of them if they live long enough? I have an 84-year-old patient that I'm going to be operating on, and she, at her age of 79, got 750 cc implants. Now, that is wrong, unethical, if you ask me. You need to educate that patient and say you do not need to at that age. Going back to, if you just listen to the patients, the whole goal is that the surgeon steps up and takes that leadership role and takes that professional role, that ethical role, and says, we truly recognize these gummy bears are not what they were meant to be. They are not safer. These cohesive gel implants disintegrate in the same manner. The surgeons should step up and very peacefully and very wholeheartedly accept the fact honorably that they are not worth putting into the patients, because the hurt is eventually so much that it does not justify putting them in young ladies and old and eventually causing them the hurt that you hear the patients talking about every single minute, every single day on social media.
Let me get back to one other thing here, and then we'll end the interview. You've given us so much great things to think about. A woman wants an implant, learns how dangerous they are, but then would be tempted to turn to some other type of augmentation which they think are safer. What do you do? How do you advise that woman?
So do your homework, learn about this other two techniques or other ways of augmenting. Remember, every procedure has its ups and downs. And so you want to be well informed about these other free flaps or other rotational flaps, where they bring the latissimus muscle from the back and reconstruct the chest. Now, each one of these has a pros and cons, and you want to be well learned and educated. Nowadays, it is very normal and common for ladies who have no medical background, stay-at-home moms, physicists, engineers that I've taken care of, ladies who are business owners. They themselves are so well read, their personalities are so detail oriented, they truly can comprehend what's going on. And I make it a point that I share with them what I know so that I can translate to them. There are many other ladies within the Facebook page that help understand and translate this to the many other ladies who are not able to understand this concept of what the capsule is and why it needs to be removed. And this is truly the sisterhood that these patients have. This website was started by one of my patients from Arizona, and now it has grown to 13,000 patients. And trust me, I did not even have a Facebook account. And so this is basically a network by the ladies for the ladies so that they can educate themselves. And the patients must, just like when you go buy a house or a car, you educate yourself about the car, what's the hurt, what's the longevity, what are the problems. And you want to sign up and understand what are the long-term implications of doing any procedure. What is very important, if you look at plastic surgery, this is overall elective. Even for cancer patients, technically, it is elective. You have a choice to not do something, especially when we know there's a mountain of evidence, like we have discussed, that speaks against it. And my take-home message in a very professional and sound way is knowing what I know, having being in the operating room since 1998 and dealing with breast cancer patients and implants and seeing them literally and reading about them, studying them. I myself, as a biochemist from undergrad, the evidence speaks against. It is, in my humble opinion, not justifiable to put saline or silicone implants. It does not justify the hurt for the limited initial temporary gain that the patients have. And ultimately, the patients, I clearly see, and you can, if you look at any of the patients, they pay a price for this. And many of the patients don't understand that this was even a potential problem that they would have to deal with.
So what is the majority of your practice now? What do you end up doing most of the time?
So believe it or not, in my practice, for someone who only put in one set of implants, I was doing all aspects of plastic surgery, from skin cancer, flap reconstruction, hand, and other trauma patients, for example. Then one patient came to me that translated to 2, 4, 8, and then the next thing you know, I was doing 15% explants, and now my practice is exclusively 99% explants. I saw a patient earlier this week with a fingertip amputation. I was like, that's a nice change, or another complex reconstruction, or a young forehead mass on a 19-year-old that I removed. But I will tell you, this is when I You know, initially had the chance, I said to myself, if I don't speak up, especially what I know, it's my responsibility that I will step up. I could never imagine in my wildest dreams that this is where it would be this far out at this phase. I could not even imagine that this is where I would be and this is what my practice would entail. I am not a Facebook, YouTube, TikTok, Instagram person at all. And now I am literally on it every day. And I'm just very humbly and sincerely, honestly doing my job. And I'm raising the awareness so that I can hopefully make this next patient's life better.
So I can't get you to do a rhinoplasty on this schnoz of mine, huh?
I will tell you, a rhinoplasty is the hardest operation in plastic surgery of the 3,000 operations. But I will tell you, I will refer you to Dr. Gowda. He's the king of rhinoplasty and the king of redo rhinoplasty. So I will refer you to that doc. For example, I will not do a cleft lip palate because that's primarily meant for the pediatric hospital. Or another surgery, for example, where you would do the free flap like we were talking about earlier. And the bottom line is, each one of us has our own niche and our own what you want to do, and you become the expert. One of the past presidents of the Plastic Surgery Society, he said that I do 8-10 operations and I'm the king of them, and that's what you want to be. And this is where you develop the expertise. My mentor of my chairman, you know, one of the, I would say, the world's best plastic surgeons, he said to me and to us when we were in training, if your car has a transmission problem, you go to the transmission guy who does only transmissions from 8 o'clock till 6 p.m. every day. You don't want to go to your local mechanic who does 2 of these in a week or 4 of them in a month, because they will not know. And this has been well established because you learn, there's a learning curve for each one of these surgeries. And the bottom line is you learn and you're always self-critiquing yourself. So you're upping your game and you're making the patient's experience the best possible.
Who is that nose surgeon you're?
Dr. Muni Gowda, Gowda.
Where is he?
He's right here in Novi. He's my mentor. He's trained me. I will tell you, he's world-class, phenomenal plastic surgeon.
Oh, well,
Yeah.
sooner or later, I'll give him a call and do an interview with him, and I'll tell him that I got the referral from Dr. Khan.
Yes.
Well, thank you. This has been Breast Implant 101, isn't it? I feel like I just went through a graduate course. Thank you so much, Dr. Khan.
Oh, you're welcome. You're welcome.
I'm sure there's questions I haven't asked, but you've given me so much material here. If I have a problem to clarify something, I'll give you a call or send a message.
If you go to YouTube, there is almost 600 videos out there. And if you go to the Facebook page, there are 5 years worth of patient testimonials, pictures, live from the operating room. All what we have said is reaffirmed over and over again. There's only 20 questions you can ask. And you will see after some time, even if you don't want to learn, you will inevitably end up learning because it's the same theme, the same concept. And you will see it basically, it's translating into clinical practice in real life, and you will see the benefit of the patients.
Thank you so much. This has really been outstanding.